Good morning. My name is Renee Rodriguez. I am from the Center for Innovative Practices at Case Western Reserve University. And the didactic today we're going to focus on is IHBT, which is intensive home-based treatment. All right. So here's our service definition. IHBT is an intensive time-limited mental health service for youth with serious emotional disabilities and their families, provided in the home, school, and community, where the youth lives with the goals of stabilizing behavioral health concerns and safely maintaining youth in the least restrictive, most normative environment. All right. So this is the most, and we're working on an updated one, but this is the most recent updated version. So you can see that IHBT, home-based, is starting to cover our state. We still have a few open counties, but definitely much better and grown, especially with Ohio Rise, which is almost, we're almost at the 5-year mark this July, I believe. And so IHBT is an umbrella program, and then there are specific programs underneath that. And so here's the map of the different counties across. So you can see here, green is most of them, and those would be the IHBT programs. And then we have a spattering of MST, FFT, and then some down here in the southern area, which has been, I'll tell you, which has been lacking with home-based programs. So I'm thrilled that it's expanding across the state. All right, so here are our home-based service models. So the original is actually Home Builders. It's still around. And this is length of stay. So it was a child welfare program, and they just went in, it was family preservation. They were in there for 4 to 6 weeks and really focused on safety and stabilizing the family. We also, within CIP, we also provide training and consultation for multi-systemic therapy. So I spent about 18 years in MST. It's a fantastic program, 50 years of research. MST standard focuses on the juvenile justice population. They also have adaptations now. One of those is problem sexual behavior, and we have a few of those teams across the state. At CIP, we also have, of course, IHBT. So that's Ohio's model. And so outside of getting to be a part of our ECHO, I get to train on IHBT and do consultation, and Mike Fox also is our consultant for ICT. And so that really just blends IHBT with co-occurring substance use behavior. And it has a developmental approach and a stage-wise matched approach for that. 2 other programs that are also implemented across the state are FFT and IFAST. At CIP, we just do not provide that training consultation for those, but you can see that both of them have a family focus, which is critical for IHBT. The population they serve is just a little bit different. So you can see here that FFT, they also include outpatient sessions. It's a shorter duration of time, only about 3 months. They tend to take less intense behaviors if we would compare that, let's say, to MST. And then IFAST has the family systems focus, but they tend to have larger caseloads and limited on call. All right. So I had mentioned earlier, Ohio Rise has been around for almost 5 years, and lots of youth and families can access IHBT through Ohio Rise once the CANS is completed. And so here's the eligibility criteria. A youth needs to be under the age of 21. And I do want to say with this caveat that if they are between 18 and 21, they need to be living at home with a family. So this is a family program. We would not serve independent transitional age youth, young people, right? Because they would benefit from a different program. So we need the family to work with. So they need to be under the age of 21. They have a behavioral health need and a CANS assessment that indicates marked to severe behavioral or emotional impairment, and either impairment that seriously disrupts functioning and or risk behaviors that are rated as actionable on the CANS. And then these next 3 are really the primary goals for IHBT. The first one being that they're at risk of out-of-home placement. And when I say out-of-home placement, that is a paid placement, a formal setting. So it could be anything from DYS, which is our Department of Youth Services, to QRTP, residential treatment facility, group home, etc. Also, the last 2 is that they're returning from placement. So it's a reunification. And then this last one, that they tend to require higher intensity services and supports than, let's say, traditional like outpatient. So if they're an outpatient, they're using a lot of on-call, police involvement, going to the hospital. There's lots of ongoing safety risks, things like that. So they're just outpatient isn't intense enough to serve them. So several rationales for IHBT. So it is the least restrictive, most normative environment. So in the home, in the community, right? It is a supportive framework to allow us to provide evidence-based practice. It is cost-effective as compared to at-home placement, significantly so. Of course, it's an alternative to custody relinquishment. If there is a family that is considering that, IHBT is a great alternative to that. And then this right here, treatment is focused on the whole family. So oftentimes when kids get to the place of needing IHBT, they have likely had maybe outpatient or other treatment, and that maybe has only produced so much positive outcomes or benefits. And so when we get to IHBT, we really focus on the whole family system for improved functioning and skills. So that's a little bit of a shift there. Also, we're able to overcome lots of barriers to engagement, transportation, et cetera. There's a 24/7 on call, so we're able to have flexible schedules. So we're really to attend to when the family is available. Of course, it benefits other child serving systems, avoids those negative consequences to placements, and then targets those high users of other services. So here's our trauma-informed behavioral health treatment array, and I kind of think of this as a pie. Slices get bigger, smaller based on what the youth and family need, as well as where you're at in treatment. A huge slice, and all throughout treatment, is this crisis response, stabilization, and safety planning. And when I say safety, that is a broad term that's going to include harm to self, others, and the community, et cetera. So it could look like physical aggression, suicidality, elopement, runaway, substance use, all of those things. And then also this cross-system collaboration and advocacy, so that we work with the other systems and providers that are involved, and then support the youth and family and advocate for them for success. Also providing family counseling, because it is a family program. And then individual counseling, so that's specifically with the youth. And then skill building for youth, parent, and family. And then lastly, this resilience promotion. So there's lots of research around the benefits of resiliency. All of that integrated in a seamless set of services that IHBT providers deliver to the family. All right, so these are the three primary goals. I had mentioned those before: stabilization and safety, placement, prevention, and reunification. And just for everyone here, because I'm going to take this opportunity to also say, MST has done some research on this, and when we compare outcomes for this placement prevention group and reunification, outcomes, not shocking, right? Outcomes are going to be better for placement prevention group. So I always recommend if any of us are ever in a meeting and they're discussing placement, we really need to strongly consider IHBT, because if that youth is placed out of the home, we have a lot more work to do when they get out, because they're also including, there's a risk, there's a family disruption, then there's the thought that like, oh, placement is always an option. And then also we have negative peer contagion, right? There's all sorts of things. So always just want to know that for anyone here, we would want to advocate for IHBT over placement. Not to say that sometimes placement is the needed thing, but not always. All right, so what does a typical IHBT youth look like? They tend to have SED with functional impairments, multiple risk factors and few protective factors, multi-system involved, which are some of the youth and families that we come across in our ECHO here today. They're at risk of placement due to safety issues. They tend to have skill set deficits and developmental gaps. Less intensive services were unsuccessful. So for example, outpatient, things like that. And then lastly, the youth needs additional supports, active facilitation, and accommodations for success. Here's the IHBT model components. And so I'm going to go over a little more specifically about the delivery modality, but you can see here all of these things are focused on throughout treatment. And I am going to kind of go through these slides fairly quickly. And you'll be able to access the slides too. Here's the delivery model. And so you can see here, home in the community, and it is like in the home. So it's not that we meet at the church or the library, which can sometimes happen, but it is in the home. The intensity is kind of like the clinical dose of treatment that we give. And that is really based on whatever the clinical need is. It tends to be higher in the beginning and phase out over time. While this is the frequency and duration, this was the dose to get effective or successful outcomes in the beginning. But I often share, like I did home-based, I did MST for 8 years in the community. I had one session that was 4.5 hours long. So it is whatever the family needs. And so it might mean everyday contact. So again, it's really based on what the clinical need is. And then 24/7, so they always have an IHBT provider that's available for support. There's also this single point of clinical responsibility. It's not uncommon that families have multiple providers and people involved. And so once IHBT steps in, we like to take the clinical lead. Some of those other services or treatments might be put on hold. And it just decreases that service burden for families. So we can kind of think about IHBT in 3 phases. So the first phase, we tend to have higher intensity. So we're meeting with them much more often, more contacts. And we really focus a lot on engagement of everyone involved, including other system providers, focusing here on crisis and safety, and then continued assessment. And then that treatment, I would say phase 1 is about the first 2 to 4 weeks, about the first month or so. Treatment is the mid 6 to 8 weeks, let's say. And so that's where we're actively utilizing evidence-based practices, skill building, building up their social support network. And then phase 3 is the last 2 to 4 weeks. And we're kind of decreasing intensity at that point. And so we're really kind of solidifying the gains made, creating maintenance plans, having a final family team meeting, and then ensuring that that progress can sustain. And then at that point, discussing if there is a need for aftercare. That's not always needed. I love doing home base. I thought it was the best job for many reasons. One of the things is that it is never dull and boring. Like you do a lot, you get to do a lot of different things. So you meet with the kid, with the family, doing counseling, therapy, skill building, working with other systems. That could mean court hearings, IEP meetings, meeting with child welfare, any other systems involved. Of course, we have this crisis availability and response. So 24/7 on call that is rotated across the team, focusing on safety planning, et cetera, and then building up their social support network. So we'll tend to do like family team meetings, et cetera. So you can see here that this would include a lot of different service hours and contexts. So in phase 1, we focus on engagement and some of the factors here. We also focus heavily on this multidimensional assessment. So diagnostically, looking at safety and risk factors, developmental, and then the other thing here, and this is our family systems, is that we're really looking at the contextual factors. What is going on that maybe is causing some disruption or difficulty for that youth in certain situations. So contextual assessment and treatment. So we're looking at all these other systems and domains. You can see here how the youth is embedded within the family. And then we're also looking at all of these and also wanting to leverage the strengths and address the needs in each of those. So assessing risk is really an important and vital part of IHBT. So we want to look at any of the factors that are contributing to the development of safety or risk or negative behaviors. Okay. And so we translate a functional analysis into safety planning as well. Also to know that 50% is actually prevention. So we create safe environments, safe contact, safe support, safe people, clearly a really detailed safety plan and how to manage escalations, utilizing supports, what is everyone's role and responsibility, actively monitoring it. It is a part of every session and clearly a big part of the whole treatment as well. And hopefully at the end, we're able to retire that safety plan. So this is just looking at the family need hierarchy and all of the different kind of layers and levels. There's a lot that goes into this, but each step of the way that we continue to conceptualize and prioritize the treatment needs. I'm going to skip over this one. Just want to mention the crisis cycle. So our focus is being trauma informed. And so we tend to see a lot of family conflict and escalations, right? And so it's helpful to understand how do things play out for that youth and family on this cycle. So there's a lot of psychoeducation that we provide to the family as well. And as we understand their crisis cycle, there tends to be similar patterns, but they're all kind of unique and different with the content. Then we want to add in these trauma-informed interventions. And so they become very specific and detailed. So this is kind of an overlay, but we would specify what would validation look like? What would you say? What would you do? So it's really unique to each youth and family. Just want to mention about protective factors for preventing suicide. And so these are all the things that we look at. What are the external constraints? Sorry, I mentioned about safe environments, safe people, building up skill sets, internal constraints if that's relevant, and then accessible care. Another part is skill building, and skill building is for the youth and family and anyone involved. And so really it's just increase those skill sets that can be applied and generalized to different settings. Some examples of skill set development for conflict resolution, social problem solving, mindfulness, and personal safety. And another big part of IHBT is really looking at the ecosystemic functioning and supports. So kind of rallying around all of their support systems they tend to be very limited. We work really hard to increase informal systems and decrease formal system involvement over time. And this, there was some work that Rick Shepler had done on resiliency. And so we leverage lots of resiliency throughout the treatment as well. And it talks a little bit about there. And then at the end, I know this was like a quick run through. Our treatment time is about 3 to 6 months. Average length of stay is about five to 5.5 months. And so this last phase of treatment is when we're kind of wrapping up. And so we talk about when to transition. It is not a surprise. It is planful, but all of the things that kind of go into the end. And so one of them is this predicting future challenges. And so we do that by creating a maintenance plan. And so it's not only a kind of overview of all the things that they've done and learned and are empowered and can manage, but also predicting future challenges. So for example, if school starts in August and we close in May, there should clearly be a plan for school starting. So this is a resiliency-oriented, just kind of overview of what a maintenance plan would look like. So you can see here, there's 3 steps. We have reviewing skills, supports, and safety plans. The second step is to predict. You want to identify potential barriers to implementing it. And then 3 is the adapt or the plan B. So reviewing skills, and then it's kind of your if then plan. Like if school bus doesn't show up or they miss the school bus, then who's going to take Johnny to school? So it's pretty detailed and building up on those resiliency and support systems. Let's see. So family resilience, what resource supports building up their skills. The other thing I think I definitely would want to say, I'm a huge fan of pro-social activities. So that is another, and mentors and supports. And so always helpful to look informally. But if we're not able to do that, also care coordination and wraparound has been really helpful in coordinating work together to make some of those things happen for some of the IHBT youth. And here is our IHBT Ohio website. There's some toolkits and resources there. And that is it.